Good afternoon, everyone. I'm very thankful on behalf of all our co-chairpersons for this opportunity to chair this session and to be invited to this very relevant and very important CME. So, like as obstetricians, we come across many patients with thrombocytopenia, ranging from the relatively benign and very common gestational thrombocytopenia to the very severe ones associated with pregnancy, severe preeclampsia, AFLP and HELP syndrome. So we have Dr. Neeraj Sidharthan here, who will enlighten us on the different types of thrombocytopenia that is encountered, and I am very sure that he'll shed light on so many of our doubts that we have regarding how to proceed with such patients, when to give platelet transfusion, what is the cutoff for a cesarean, what is the cutoff for a delivery. So over to you, Dr. Neeraj.
Thank you very much, Madam. Good afternoon, and thanks to Jay Sir and APA Kochi for this opportunity. Really a pleasure to be here with all of you. So, as Madam mentioned, the thrombocytopenia, or the low in obstetric hematology, if you look at a value, the platelet value is one which always sends our anxiety sky high, and also may require a lot of wisdom how to act on it. So I will start with a case which many of us similar cases would have seen. A 32-week primary gravida presenting with a mild gum bleed and has fever, and then has transaminitis, a platelet of 38,000, and on evaluation we have dengue NS1 positive. So it's a third trimester thrombocytopenia, but we have a reason for it, that is, it's dengue related. And in such situations, do we need to transfuse platelets? Essentially, the support care is very important here. Avoid NSAIDs, and platelet transfusion is not always a must in such cases, but it has to be judicious, and when there is a bleeding, you transfuse, or if there is a procedure, we transfuse, or if it goes very low only. So here in this patient, thankfully the platelets recovered, and we could proceed with the term vaginal delivery without much problems. Okay, so now I wanted to take you through this slide, which largely looks at most of the reasons of thrombocytopenia encountered in pregnancy. Starting with gestational thrombocytopenia, then ITP, and then we have preeclampsia, fatty liver, TTP, HUS, SELI, phospholipid syndrome, TIC, viral infection, which we saw, nutritional deficiency, drug use, and marrow disorders like leukemias and aplastic anemias can also present with thrombocytopenia. But in general, when you look at thrombocytopenia alone, because marrow disorders usually present with multiple cytopenias, and it may have peripheral blood contributing to some other diagnosis being evident. But the common causes, if you look at it, thrombocytopenia will affect 7 to 10% of pregnancies, and most common cause, of course, is gestational thrombocytopenia, roughly 70 to 80%, followed by preeclampsia or HELP, which is 15 to 20%, followed by ITP. The most important task is for us to distinguish between a benign from serious etiologies, because in serious etiology you could have even the chance of mother's death and even chance of child's death. So this figure will broadly tell us what are we likely to see on a probability scale. So if you look at the first trimester, mostly if a patient presents in first trimester with thrombocytopenia, while the most common thing that you may see is an ITP presenting there. Whereas if your patient is presenting in second and third trimester, especially if the platelets are more than 1 lakh, and there you could say the most likely possibility is gestational thrombocytopenia. The platelets coming down in the third trimester, usually if it is less than 50,000, you need to look out for preeclampsia and likewise disorders. This is also a snapshot where which some of this I have already mentioned, but Madam was mentioning some of the thresholds that we want, especially for transfusion, even in the absence of bleeding. In the presence of bleeding, generally it's less than 50,000 platelet count. If you have bleeding, that's when we transfuse. But in the absence of bleeding, it's like maybe when it is less than 20,000 during pregnancy and more than 50,000 for cesarean section and 70,000 for neuraxial anesthesia. The ITP treatment that we can give in pregnancy would include corticosteroids and IVIG. The mode of delivery generally is as per obstetric indication, and you would want to consider active management of the third stage of labor. It's also important to remember that yes, thrombocytopenia in mother is not necessarily limited to mother, and the child also may have thrombocytopenia, especially if it's immune. And it's important to avoid instrumental delivery, such as mother also sometimes may have hereditary thrombocytopenia, which may be present in the child as well. So first, let us look at gestational thrombocytopenia. It's a second to third trimester disorder, and more than 70,000 usually, and it is resolved postpartum. There is no neonatal thrombocytopenia, and there is no treatment required. What is the reason for gestational thrombocytopenia? One of the reasons is hemodilution. Second is in pregnancy, there would be a combination of different factors, including increased von Willebrand factor, insufficient thrombopoietin response, and reduced Adams 13 activity contributing to it. So, if you look at the complete blood count, you could, in a gestational thrombocytopenia, you could see some higher mean platelet volume. So, in that complete blood count, you could see a higher mean platelet volume there. And if you measure TPO, that you could see that might be higher than what you see in ITP. So, epidural anesthesia, this is. So, in the earlier talk by Mithun, when he was mentioning about aspirin, I was just realizing that there are not much evidence-based guidelines in thrombocytopenia, no randomized controlled trials. So, the best that we have is a few guidelines. So, as per guidelines, it is 70,000 for epidural anesthesia. It is a bit debated whether you can do at a lower number. So, with that, we'll come to ITP. ITP is where you don't have other diagnosis and it is immune, and it occurs in about 0.1% of pregnancies. It can be first detected during pregnancy. The patient sometimes may have ITP diagnosed prior to it. And it's the most common cause of thrombocytopenia in the first trimester. ITP usually doesn't resolve after delivery, unlike gestational thrombocytopenia. So if you have ITP, then what should be the target platelet count during pregnancy? So again, if the patient doesn't have bleeding, you could keep a target platelet count of 20 to 30,000 and keep the patient under close monitoring. Okay, so, and what is the treatment for ITP? The treatment for ITP, as I mentioned earlier, is corticosteroids and IV immunoglobulin. What type of corticosteroids can we use? We can use prednisolone because it is very little amount is secreted in the cord blood compared with the other steroid that we can use is dexamethasone. And so, in the maternal toxicities of prednisolone can occur, and some first trimester fetal effects like cleft lip, cleft palate can occur. And the onset of prednisolone is slightly lower than dexamethasone. So, if you want a really fast action, then dexamethasone or IVIG may be important. The dose of IVIG is 0.4 a gram per kg per day, which can be given 1 to 5 days. So, how do you monitor the platelet count? In general, you can monitor it if the patient is stable. You can monitor it with every 4 weeks. Or if when you closer on the delivery time, trimester 3, it has to be every 1 to 2 weeks. However, if the platelets are low, we do monitor it more closely at 1 to 2 weeks, even earlier in the pregnancy. And sometimes we can give IVIG if the IVIG the problem is the cause, but otherwise you could give it staggered. When the platelet goes down, you could give IVIG a small dose and then keep it up and so because if you keep the patient on prednisolone for a very long time, they tend to develop a lot of toxicities. And as I mentioned earlier, it is important to consider fetal problems in ITP because fetus may have thrombocytopenia, and we have to take preemptive actions and avoid forceps delivery. And as soon as the fetus is born, the neonatal platelet count is needs to be monitored, and this message needs to be given to the neonatal unit. It is also important that sometimes the other drugs that we use for ITP, it is not always that the ITP responds to steroid or IVIG. So azathioprine is reasonably safe during pregnancy, especially second and third trimester. The other drugs that we can use is rituximab, cyclosporin, splenectomy in the second trimester. Anti-deimmunoglobulin is not very popular because of the risk of hemolysis, so that we don't use much of splenectomy or anti-deimmunoglobulin. I know most of you might be asking questions on TPO-RAs, L-thrombopag and romiflostin, because these are very easily available drugs now which can cross placenta. So the problem is it can cross placenta and it can cause thrombocytosis in the neonate. So it is also, even when in a prothrombotic stage like pregnancy, it has to be used with caution, and thrombotic tendencies can occur. So as of now, it is not an approved drug in pregnancy, but there are some literature which, if you really want to use this, you can refer to this article in Blood, which tried looking at a lower dose of TPAs for a shorter period, and then tried to look at whether it is safe. So TPO-RAs, the short answer is, as far as possible, I really avoid using it, but if you have to use it, you have to use it with utmost caution, considering the thrombocytosis in the neonate as well as thrombotic risk in the mother. So with that, I'll come to a case. This is something which we haven't discussed so far. It's a antiphospholipid syndrome patient at 20 weeks of gestation, and the patient is on with a previous history of DVT on aspirin and low molecular weight heparin twice daily. On routine investigations, the platelet count is 68,000, and the question is how anticoagulation should be managed at this stage of pregnancy with 68,000 platelet count. If there are trainees, and could you please scan the QR code quickly if you want to answer this? I will have to move a bit fast because of the time. So these are the four choices: to stop aspirin or low molecular weight heparin until the platelet normalize, continue both drugs, continue aspirin and reduce low molecular weight to prophylactic dose. Which one would be it? So the answer is low molecular weight. You can continue aspirin but reduce low molecular weight to prophylactic dose. The reason is that this is thrombotic APLA, and the initial this is one instance where you need 2 times heparin. The therapeutic low molecular weight heparin is recommended. And so with the platelets coming down, the bleeding risk goes up, and that is why we have to downgrade this one. However, if you monitor platelets and platelet recovers, then you can put the patient back on heparin. So the other case is a 27-year-old lady, 28-year-old lady with the 27 weeks gestation and slightly higher blood pressure, dark urine, mild confusion, HP8, platelet 24,000, a little bit high retic count, nucleated red cells on the peripheral smear, a high LDH, and some abnormal LFT, some abnormal RFT, urine proteinuria. So what is your most likely diagnosis here? So is it HELP syndrome, TTP, atypical HUS, or severe preeclampsia with MHA? What do you think is the answer? So the answer here is TTP, and I'll tell you why. This Even though the smear doesn't have schistocytes, it doesn't rule out microangiopathic hemolytic anemia. So that is very important. You don't need schistocytes in the smear to diagnose MAHA. The labs here clearly show the hemolysis, and the timing is 27 weeks. You could have HELP or preeclampsia also at this time. You have a disproportionately high LDH, and that tilts us the diagnosis towards the TTP here. And the smear shows NRBCs, and you could check the Adams-Tayes level for confirmation. So what are the thrombotic microangiopathies in pregnancy? So you have preeclampsia, HELP syndrome, and acute fatty liver of pregnancy, which I think you commonly see. And the important thing about all these three thrombotic microangiopathies is that delivery is the treatment for all of these. And the other three, which may be rarer but also a bit catastrophic, is TTP, HUS, and catastrophic APLA. And this we have to manage like in a non-pregnant patient, like plasmapheresis, etc. So there are why pregnancy has a higher incidence of such thrombotic microangiopathy, because the gravid endothelium has some kind of trigger for triggering this. In addition, you have the increased von Willebrand factor and reduction in Adams-13 activity, and also activation of complements happening in pregnancy, leading to the different microangiopathies. So preeclampsia is by and large the commonest, followed by HELP, and TTP is rare. Even though it is rare, it's very important to be aware of it, and because it can occur throughout the pregnancy, although it's most common in the third trimester. If you have a first trimester presentation, again it's likely to be TTP. Between 20 weeks and postpartum, every one of this is very likely. And usually the absence of stabilization after delivery rules out the preeclampsia and HELP syndromes. Although Adams-13 is diagnostic for TTP, don't wait for this to start plasmapheresis if you have a suspicion of TTP. You can send a sample and then act, and then decide on plasmapheresis later. Decide on the Adams-13 activity results later. So in general, the clinical clues for TTP is that platelets more than 30,000 and creat more than 2, that scenario TTP is very unlikely. So this is about the preeclampsia. So what happens in preeclampsia is you have an abnormal placentation, and you have this anti-angiogenic proteins like SFLT1, which goes and binds to the angiogenic proteins like VEGF, and then causes hypertension, organ damage, and microangiopathy in the blood. So that causes thrombocytopenia. So again, the different organ damages that can occur in preeclampsia, I think all in this audience are very familiar with. So I just wanted to show you this picture. See, on this blue, we have preeclampsia, and then on this, we have acute fatty liver, HELP, TTP, and HUS. If you see the green circle, the green circle is where the thrombocytopenia is. So HELP has thrombocytopenia, preeclampsia has thrombocytopenia, acute fatty liver has thrombocytopenia, HUS and TTP has thrombocytopenia. So it is very important that we have a broad differential diagnosis, especially when you see such pictures. And it is tough. It's not easy to distinguish between each of these. So this figure actually tells us the clinical characteristics in density of likelihood, how we differentiate between all this. So it's not easy. So all of these can be overlapping, but then there are subtle things which we have gone through earlier, which tells us whether it's a TTP or HUS or acute fatty liver of pregnancy or HELP or preeclampsia. If time permits, we can discuss that during the Q&A session. This is how how we treat HELP. In addition to, especially as I mentioned, HELP, the delivery is a very important treatment. But if the platelets are low, dexamethasone is an important drug that you can give, and that is the doses, and that might help to achieve a better platelet count and reduce the bleeding risk. Now, with respect to the TTP, and I mentioned Adams 13 activity earlier, if it is less than 10%, that is where we diagnose a TTP. And in pregnancy, TTP can be an acquired TTP, and also congenital TTP can also first time present during pregnancy. And once you have a TTP in the pregnancy, and if you have initiated plasmapheresis and all that, and the patient comes out well, in another pregnancy, we have had at least 3 or 4 patients where the TTP recurred in the subsequent pregnancy. So it's important that we find out whether it was an acquired, even if it's an acquired Adams 13 deficiency or a congenital Adams 13 deficiency, we can detect by doing the antibodies. Both of these conditions can be recurring in subsequent pregnancy, and we have guidelines now how to monitor this and Adams 13 and take preemptive action like low dose steroids and prophylactic plasma exchange therapy. So as we conclude, I think a few take home messages is that most thrombocytopenia in pregnancy is benign. Platelets less than 70 or an early onset thrombocytopenia, definitely you need to investigate. Always review the peripheral smear. Look out for the bad things like marrow stress. Distinguish ITP from HELP and TTP by the systemic clues that you get. And the delivery planning must be multidisciplinary. If I can take one more minute on the next few slides, thanks. So this is a case scenario again, 36-week primigravida with 72,000 platelets count. So in the background of what we talked, how should we proceed in this case? So this is 72,000, third trimester, confirmed thrombocytopenia, exclude clumping. So one of the things is to look at pseudothrombocytopenia. Sometimes you look at the peripheral smear and you could say, so do that, repeat the count and confirm, review the smear and see if there are schistocytes. And now the timing is the third late pregnancy. Look at all the BP, urine protein, and LFT, renal function to look for microangiopathies and systemic symptoms for microangiopathies. So late, mild, asymptomatic, more than 70,000 would be gestational, or early isolated less than 70 would be immune. If you have the associated features of hypertension, hemolysis, LFT, then you should think about the microangiopathy cohort. Okay. Finally, what can cause? It's important to know what are the maternal and neonatal outcomes and the data that we have. So, gestational thrombocytopenia, no risk of maternal mortality, no risk of fetal mortality, and platelets normalized within 4 to 6 weeks postpartum. Immune thrombocytopenia, maternal bleeding risk is less than 5% if managed properly. Neonatal thrombocytopenia risk is 10 to 15%. There is a risk of intracranial bleed in neonates, even though it's less than 1%. HELP and preeclampsia, maternal mortality is 1 to 3%. Perinatal mortality is even more, up to 10% in severe cases. Thrombotic microangiopathies is more fatal with maternal mortality high, so it is important to start plasmapheresis, and with plasmapheresis the mortality risk comes down significantly. The fetal survival is approximately 70%. So with that, I finish my presentation. Thank you for the patient listening.
Thank you, Dr. Neeraj, for the excellent disposition of the topic now. Before going the discussion, 1 minute, we are very overwhelmed to hear from Paili sir. Paili sir was our teacher at Calicut Medical. We were wondering why sir was not awarded a Padma Shri. So truly he deserves it. Must congratulate the organizers of the APA question for this conducting this wonderful CME. Many a time we physicians are called for we have the cross consultations and we are worried. We are a bit uncomfortable when we get a call from the OBG side. Because of this is the one specialty where the unavoidable medical complications are misinterpreted as the medical negligence and or the hell of the problems. No, so Dr. Neeraj has very much, very well highlighted the role of in between. You talk about the pseudo thrombocytopenia also, so can happen in 1% of the pregnancy. So, we have the ACCP guidelines says you can wait up to 10,000 the platelet to drop in a low risk, no bleeding cases. What about it? What is the scenario in pregnancy?
Yes, sir. So I think, as I mentioned again before, so there are limitations to the evidences that we have on the thresholds. So 10,000 is for an ITP. We don't have thresholds for transfusions at all. If the patient is not bleeding, even at 10,000, you don't need to transfuse. Whereas for treating the patient with a medicine like steroid or IVIG, it's a slightly higher threshold that is recommended, that is 20 to 30,000. The threshold for intervention is higher. That's 30,000 if the patient is, 50,000 for anything other than neuraxial anesthesia, and 70,000 for neuraxial anesthesia.
Suppose you want to increase the platelet count very, very fast, which in a case of ITP, which is your preference, whether we IVIG or the steroid?
Sir, I think the IVIG is the fastest by and large, even compared to among the steroid, prednisolone and dexamethasone. Dexamethasone is faster. The IV dexamethasone is faster than prednisolone. So, and IVIG is the fastest. So, if given a choice and if the patient has no issues for the higher cost of IVIG, it's always better to go for IVIG if time is a big concern. If IVIG is not possible, with the caveats of the toxicities of dexamethasone, we can use the dexamethasone.
Dr. Neeraj, you have covered the entire spectrum very well. I just wanted to highlight that the platelet count alone should not be an indication for the mode of delivery. So the mode of delivery is irrespective of the platelet count. That is one thing I just felt like highlighting, irrespective of the count. The underlying pathology has to be treated, and the thrombocytopenia alone should not dictate whether it should be a delivery or a cesarean. The only thing is the cutoff, like you said, the threshold should be at least 50,000 for a operative delivery and at least 70,000 for a regional anesthesia. Is that correct?
Yeah, so that's, you are absolutely right, madam. So, and platelet count by itself should not be determining which route of delivery you are taking. It should be an obstetric indication, largely. There has been, although we have the guidelines, say 50,000 for cesarean section, sometimes it's not always possible, and obstetric indications sometimes warrant a cesarean section. So we have had instances where the platelet count has been absolutely refractory, and we had to take up the patient for cesarean section at less than 10,000 platelet count. So we try to take all other precautions, transfuse platelets at the time of anesthesia and incision, avoid neuraxial anesthesia, give some tranexamic acid and all that.
Excellent presentation, Dr. Neeraj. Just two doubts. One, the patients with thrombocytopenia, especially gestational thrombocytopenia, if the patients come and ask whether can they take caripil, something like papaya extracts, what suggestions should we give?
Yeah, so there was a trial, randomized study conducted at our institution by a few years back on caripil. That is oral drug like caripil, and that was in the context of dengue infection. And there was, I think the results showed that there was some increment in those patients who took caripil in the context of a dengue infection. But other than that, for a transient reason, so what I tell my patients is that in such a context it has been studied and results have been there. But otherwise, we don't have much data on which we can speak about it. Yes or no, I don't know.
And platelet transfusion of other blood groups.
Yeah, that's a very good question. So I mean, it's like it's sometimes a very sensitive thing because platelet transfusions can cause allergic reactions more often than the blood PRBC transfusion. So as far as possible, we can transfuse across the groups, no problem. Platelets, unlike the PRBC, you can transfuse across the group. But as far as possible, if the same blood group is available, that would be the wiser choice. And if at all we are transfusing across the group, it is important to talk to the patient and the bystander and take them into confidence in our setting. I think that is important. Otherwise, people are very sensitive about other groups. It can be done. In an emergency, we don't really care about which group you can transfuse. But if it's an elective transfusion, definitely try to stick to the same group.
Dr. Neeraj, thank you for a comprehensive coverage. Two questions. One is, I think I'm sure you're getting a lot of references for thrombocytopenia in pregnancy and even otherwise. So how much is attributed to pseudothrombocytopenia, and how would you evaluate pseudothrombocytopenia for the benefit of the audience?
Thanks, Renoy, for that question. So pseudothrombocytopenia is when your Coulter or your automated counter says platelets are low, and when you actually do the count in a smear or manual count, the platelets numbers are normal. And this is not uncommon. In the last but one slide, I mentioned that we should repeat the platelet count and also do a peripheral smear. So if a peripheral smear often picks up the cause pseudothrombocytopenia. The reason for pseudothrombocytopenia is often two things. One is the clumping, the platelet clumps, which can occur with EDTA, reaction with EDTA and the tube. And in such cases, you could use an alternate anticoagulant and find out. So these clumps are going to be very evident on a peripheral smear. So doing a peripheral smear will definitely help us sort it out. Other thing is the macrothrombocytopenia, which constitutional macrothrombocytopenia, especially since we have a lot of people from other states working here. And northeast and eastern part of the country has a lot of patients who have platelet count around 90,000 to 1 lakh 20, 30, 40,000. So these are not really problem causing thrombocytopenias, and not strictly the pseudothrombocytopenia, but then a mild thrombocytopenia, which will be genetic or constitutional. Or although genetic, there are many thrombocytopenias which have platelet dysfunction, which needs to be evaluated further. So a good clinical history will be important there to see if there is a platelet dysfunction.
So the next question is the scenario that you actually mentioned about APLA. The response was actually to maintain the same low dose aspirin and probably reduce to prophylactic dose. What if a differential diagnosis is heparin-induced thrombocytopenia itself?
Yeah.
In that particular scenario.
Yeah. So it's good that you asked this question, because I had to move fast on that slide because of the timing. It is very important that when a patient who has already taken heparin, you need to think about heparin-induced thrombocytopenia as a differential. So we have a HIT score, the HITT score, which looks at the probability. So HIT score has low probability, intermediate probability, or a high probability. So in this patient, it was a low probability. If you have an intermediate or a high probability, if you have high probability, after calculating the HIT score, it is HIT, and you have to treat as HIT. If you have an intermediate probability, the recommendation is to look for PF4 antibodies, and if PF4 antibodies are positive, treat as HIT. If it is a low possibility, it's something else.
Yeah, I think of lack of time, I think we can take a question from the audience.
I don't remember the age of the patient. I think she was in her 25 years, and she was second trimester. She was diagnosed with dengue. It's a patient of mine, and she had low-lying placenta, and she was infected with dengue, and her counts were initially 1 lakh, and it fell down to 70,000. And so, but we had to refer the patient with we couldn't keep her in our hospital. So what kind of treatment would you recommend for a patient like that?
Yeah, so in this patient, originally the platelet count was normal. You had recorded a normal platelet count, right? And after she contacted dengue, the platelet count dropped down and to 70,000. So in the context of dengue, there is a dengue-related thrombocytopenia, and the other possibility is a dengue-related HLH. So if you look at more sinister possibility, is a dengue-related HLH, which can also start off with the thrombocytopenia. Dengue-related thrombocytopenia is mostly benign in the sense it doesn't cause, it doesn't usually need platelet transfusions or anything. You just need a careful watch, and it is usually occurring at the time of hemoconcentration. So rather than giving platelet transfusion, it's you treat the hemoconcentration, give fluids and all that. And keep a watch on the platelet count. Mostly we try to avoid platelet transfusions during such scenarios, and unless, of course, there is a bleeding tendency. And did I answer your question? Thanks.
So I think because of lack of time, we'll wind up the session.